Welcome to Health Assessment. And today, this is Jada, and I will be giving you your podcast for skin, hair, nails, eyes, ears, nose, and throat. And then there's a secondary podcast as well that's posted on Blackboard. So we will get started. I'm going to check, make sure we're rolling here. Okay. That's all I needed to know. Okay, like I said, we're going to start off with the skin, hair, and nails. Okay, what is your skin? Your skin is what covers and protects the internal structures of your body. It is going to consist of two distinct layers, the epidermis and the dermis. The subcutaneous tissue lies beneath these layers. Here's a picture of of what your skin and your hair, and it has the different labels. These are out of your book. Okay. Now the epidermis is going to be your outer layer of skin made with squamous epithelial tissues, and then the dermis is that thick, deeper layer. And it's going to be of mainly connective tissue and extracellular materials. Okay, and then you've got the subcutaneous tissue, which is beneath the dermis and epidermis, and consists mostly of adipose tissue. Okay, your hair is formed from keratin and produced by matrix cells in the dermal layer of the skin. Each hair lies in a hair follicle, and you can see that in the picture. Okay, nails are going to be formed when the epidermal cells are converted into hard plates of keratin. We're going to go ahead and start with alterations in skin integrity, and we'll go into assessment after that. First off, we talk about skin cancer. Skin cancer is very concerning. It's a major issue that goes on today, and it can be deadly depending on the type of cancer. So we have three types of most common forms of skin cancer. It's going to be melanoma, basal cell carcinoma, and squamous cell carcinoma. Okay? We may have benign or cancerous lesions. Okay, lesions, they may be benign, like a mole, something of that sort. They could be benign like a mole. However, changes in an existing growth on the skin or a new growth that ulcerates or doesn't heal could indicate cancer or a precancerous lesion. Okay, so a benign nevus or a mole is going to be symmetrical, round, or oval shaped. It's going to have sharply defined borders, uniform, usually tan or brown color, less than 6 millimeters in diameter, flat, or just a little raised. Okay? You can have precancerous, and that's going to be abnormal changes in the keratinocytes and can become squamous cell. And that's just another type of precancerous issue that we could have. Okay, with basal cell carcinoma, it's the most common skin cancer. Usually spreads only locally. Squamous cell begins as a firm red nodule or scaly, crusty, flat lesion. Can spread if it's not treated. And then malignant melanoma, that can arise on normal skin or from an existing mole. If it is not treated properly, it can spread to other areas of the skin, lymph nodes, or internal organs. Okay? Risk factors that for skin cancer are going to be things like sun exposure. That's why we push wearing SPF all the time. Not only just in summer months, wear them all the time. Non-solar sources of UV light, that's your tanning beds. Okay, medical therapies, family history and genetics, moles. If somebody has moles all over their body, they've got more of a risk of skin cancer. Pigmentation irregularities, fair skin that burns and freckles easily, and light colored hair. Age, male gender, sorry guys, chemical exposures, human papillomavirus, ectoderma pigmentosum, long-term skin inflammation or injury, alcohol intake and smoking, and then inadequate niacin in the diet. Okay, when we're inspecting lesions, this is what we're looking for. Inspecting the lesions. Examine the skin for suspected lesions using the ABCDE mnemonic. Okay? So A is for asymmetry. So if you could draw a line through the middle of the mole, the half of the melanoma won't match. They're not going to match. They're going to look different, okay? B is for border. The edges of an early melanoma tend to be uneven, crusty, or notched. C is for color. Healthy moles are uniform in color. A variety of colors, especially white or blue, is very bad. D is for diameter. Melanomas are usually larger in diameter than a pencil eraser, although they can be smaller. E is for evolving. When a mole changes in size, shape, or color and begins to bleed or scab, that is going to point out some danger, okay? E can also be for elevated. Is it elevated? Okay, so evolving, elevated, enlarging. There's a few different ones for E there. Okay, so it's up to all of us to keep an eye on our own bodies and look for moles that are abnormal. My dad has had one that on his face they just removed, and they're quite sure it was benign. They just sent it off, but it had been there since he got back from Desert Storm in the early 90s. He was in the military. He'd been there since then, and now it started evolving. It was changing in size and shape, so the doctor removed it. Okay, when we are talking to people and we're assessing them, this is what we need to know. You can tell if they have body odor problems. You can smell that. Do they have skin? We're going to look at do they have skin? Yes, they have skin. Do they have skin problems? Is what I mean to say. Observe the skin's overall appearance, and then inspect and palpate the skin area by area, and focus on the color, the moisture, texture, turgor, and temperature. That's what we're going to see. We're looking for those skin problems, those rashes or lesions, dryness, oiliness, drainage, bruising, swelling, and pigmentation. Just because they have maybe a pigmentation issue on their arm doesn't mean their entire body's going to be affected. So we need to check everywhere. Changes in lesion appearances. Like I said, we're going to look for color. So when we're looking at the color, look for localized areas of bruising or cyanosis, pallor, erythema. We're going to look for uniformity of color, like I said. If there's any hyperpigmented areas. When we're looking at color variations in dark-skinned people, this is something that we run into, and as nurses we need to understand how to do this, because someone with darker skin may not present with cyanosis the way you or I do, and they're most likely not going to. With cyanosis, we're going to look at their conjunctiva, their palms, their hands, soles of their feet, maybe their buccal mucosa, and their tongue. Look for a dull, dark color. When we're looking at edema, we're going to examine the area for decreased color and palpate for tightness. Jaundice, is going to really be looking at the sclera, the hard palate. With pallor, we're going to examine the sclera and conjunctiva, the buccal mucosa. Petechia, we're actually looking for lighter pigmentation areas such as the abdomen. Look for tiny purplish red dots. And rashes is going to be really palpating the skin for texture changes. When we're looking at moisture, we want to see what the moisture content is. It should be relatively dry with a minimal amount of perspiration. And that's how we would document such. Texture in the turgor. Inspect and palpate the skin's texture, noting that it's thick or what its thickness is and the mobility of it. It should look smooth and be intact. The skin turgor, we're going to gently squeeze the skin on the sternal area or the forearm and between our thumb and forefinger as shown. In the book, it shows lots of pictures like that. The skin returns to its normal shape. The patient has normal skin turgor. I don't like the word normal, so know your time frames, know how to document that. Okay, temperature, we're going to palpate it bilaterally. Always palpate bilaterally. Also, we're looking for hair loss and changes, nail changes, family history, what's going on there, personal health history, their lifestyle and health practices, what their exposure to sun is. Are they in the sun a lot? Are they outside a lot? Do they drive a truck? I had a patient in ICU one time who had driven a truck his entire life and he never had insurance, and by the time he got to us he had such bad skin cancer to his nose and his face. His entire left side of his face had eroded. Why was it his left side of the face? Because he'd been driving, right? What they do to take care of their skin, their hair, and their nails. Okay, so we're going to get ready for this. And how are we going to prepare our client? What equipment would we need? Okay, when we're preparing the client, we want them to be comfortable. We want them in a room where we'll be able to see, that'll be private, that they can talk to us. We want them to be comfortable in there, check the temperature of the room, things of that sort. And then what equipment would we need? Let's see here. Of course, we're going to need our gloves, an examination light and a pen light, magnifying glass, centimeter ruler, Wood's lamp or Wood's light, a gown, and then your braiding scale. And we're going to talk about that. Next, I threw in here, because the number one question I'm asked is, what's a Wood's lamp? And it looks just like this picture, and it's a small handheld device that uses a black light to illuminate areas of the skin. The light is held over an area of the skin in a darkened room, and in the presence of like bacteria or fungus or changes in the pigmentation will cause the affected area of your skin to change color under the light. Okay, Braden scale. We use the Braden scale to assess for the skin integrity if there's a risk factor for pressure ulcers. Okay, so we'll use this Braden scale for that. And this is how we are going to assess these. We're going to look at them and see their sensory perception. So this is the ability to respond meaningfully to pressure-related discomfort. So you're sitting in your seat right now listening to this, and your bottom starts to hurt. Well, you're going to shift around a little bit. You're going to move. Well, if somebody has completely limited, so they're unresponsive, they don't moan, flinch, or grasp to painful stimuli, they're not going to know if it's hurting the way they're laying. So what's that going to do? That's going to be constant pressure on those bony prominences. Those bony prominences that are so easily, it's so easy to get pressure ulcers or skin impairment issues. Okay, slightly limited, so they may respond to verbal commands, but they can't always communicate discomfort or ask to be moved. Okay, they may have a cognitive issue. They can't ask to be moved. Moisture. So it's the degrees to which skin is exposed to moisture. If it's rarely moist, usually dry, linen only requires changing at routine intervals. That would be best, right? Or is the skin all the way on the other end constantly moist? Okay, maybe they have a great deal of edema, and maybe their legs are weeping. There's a lot of moisture there. Okay, how active are they? Walks frequently, walks occasionally. Are they bedfast? Mobility. Can they change and control their own body positions? Nutrition, what are they eating? Nutrition plays such a huge part in a patient's ability to heal and to stay healthy. And then friction and shear. Okay, so you'll see down here at the bottom the risk scale. 23, 22, 21, 20, 19, no additional pressure support required. If it goes down to 18, 17, 16, 15, there's some foam mattresses or some kind of overlay maybe they could use. Now it gets into severe when it's like 9, 8, and 7. They're going to need special mattresses, things of that sort. Okay, when we are looking, we're going to looking for any distinctive odor, color variation, skin breakdown, any lesions, and then we're going to palpate. Okay, we talked about inspection, what's supposed to look like. Now we're going to palpate. We're going to see if there's feel for lesions, the texture, the temperature and moisture, thickness of the skin. Okay. Alrighty, skin problems. So here's the pressure ulcers and skin lesions that we may run into. So we can look here at some of these pressure ulcers. Okay, so a stage 1 is going to be, you're going to have not intact skin. There's nothing open there, but it's non-blanchable. Redness of a localized area, usually going to be over a bony prominence. Then we're going to get into stage 2, so that's going to be partial thickness loss of the dermis, presenting as a shallow open ulcer with red-pink wound bed. Stage 3 is going to be full thickness loss. So with this, you'll see subcutaneous fat, but bone, tendon, or muscle are not exposed. Slough may be present, but does not obscure the depth of the tissue loss. This also may include some undermining. Do you know what undermining is? Undermining is when you have a wound, and then it appears to be 2 inches. 2 by 2 in diameter or whatever. You can say circular 2 inches. But underneath, you see that the wound, the outside of the wound is 2 inches, but once you look into the wound, it is actually undermined, which means it's bigger than what it appears on the outside. You can also have tunneling, which is what it says. It's tunneling in the skin. So you have to measure this. You have to see what that undermining is and what the tunneling looks like. And you have to measure it. Then we have stage 4, full thickness, tissue loss. And this is when you're going to see tendon or muscle or bone. Okay? Sometimes you're going to have like the suspected deep tissue injury. So that's going to be that purple or maroon localized area of discolored intact skin. The problem is you don't know what it's going to be underneath that. It may just look like a deep tissue injury, but it could open up and be pretty bad. And then unstageables, what we're going to call, if we cannot see the base of the ulcer, if it's covered by slough or yellow, tan, gray, green, or brown, any kind of eschar in the wound bed. If you can't see that wound bed, then that's going to be unstageable. This is some of the skin lesions. These are, they're in your book, so make sure to review them, what they are. It's best in our documentation and when we're talking to somebody, instead of saying that bump, to know, when we're documenting, we want somebody to know what was that we were looking at, okay? Was it erosion? So it looks like the epidermis is gone, the loss of the epidermis. Is it a vesicle, which is going to be less than 1 centimeter, or a bulla, which is going to be more than 1 centimeter. Okay, that's going to be filled with free fluid. Okay, so it's good to know what those are. Okay, when we're inspecting the hair, we're going to look at the hair. We're looking for the color and the condition, cleanliness. We're looking for, is it dry or is it oily? Are there parasites there? What kind, amount and distribution of the scalp, body, axilla, and pubic hair. We want to see what that is. Okay. With the nails, we're looking for grooming, cleanliness, color, markings, shape of the nails. Assess the texture and consistency and the capillary refill. So when you're doing this focused assessment for the hair and the nails, make sure that you're talking about all of these different areas. When we're talking about the assessment of the hair, we want to say it's evenly distributed. Things of that sort. We want to be able to describe that, not normal hair. No use of the word normal. When we're looking for the nails, we want to say that the nails are pink. The surface is slightly curved or flat, or the edges smooth or rounded. Okay, we're going to see the texture, the consistency. When you're looking and you see, maybe, if I can get it to zoom in a little, nail clubbing. Okay, this is what nail clubbing is. And that you're going to see somebody who has COPD maybe. Okay. Alright, on to the eyes. Okay, so this is the nail anatomy, or the, goodness, I'm still on nails. The eye anatomy. So you know where the eyelid, the pupil, the iris, we've got the sclera, the upper eyelid, the eyelashes. We know what those are, and that's just a reference for you. Okay, the vision. When we're assessing the vision, these are the things we're going to pay attention to in assessments. The subjective data here that we're looking at, we're going to look at what their present health concern is, what their past health history is, family history is, anything of that sort, lifestyle or health practices. And then the objective data. So this is going to be when we're looking at the client, the equipment we need. We're going to need Snellen chart or the E-chart. We're going to use the handheld Snellen chart. So we're going to assess their vision with the Snellen charts. The pen light, we'll need a pen light. The opaque cards, maybe an ophthalmoscope. Things of that sort to get the objective data. Okay, so distance visual acuity. This is one of the most common things that we do. I'm sure you've had it done. So this is the Snellen chart that you're looking at. And this is going to measure the distance visual acuity. So we're going to have them stand about 20 feet from the chart. We're going to have them cover their eye, one eye at a time. Ask them to read the letters on one line of the chart, and then move downward to the smaller lines until they can no longer discern all of the letters. And then we're going to have them repeat the test and cover their right eye. Then we're going to have them read the smallest line they can read with both eyes. And if they wear glasses, you're going to have them do it with both. The corrective lenses and without. And then we're going to record it. And the way we record it is, so we're on, these are our lines. So notice all of these say 20. So that's because we're standing 20 feet back. And normal vision is 20/20. I said the normal word. 20/20. So this is the line they should be able to read 8 if they have 20/20 vision. Now if they have 2200, then all they're going to be able to read is the E. Okay, the near visual acuity. And it's going to be conducted with a handheld vision card. It's called like a Rosenbaum card. You can use newspaper and have them read it at arm's length away. Things of that sort. But the most accurate is going to be this Rosenbaum card. It's used to evaluate the near vision. It's E's, X's, O's in graduated sizes. Has different numbers and letters. Okay, and we're going to have them hold it about 14 inches from the eyes and read the line with the smallest letters that they can distinguish. We're going to repeat the test with the other eye, and if the patient wears corrective lenses, same as with the Snellen chart, have them do it with both. Okay. When we're doing our assessments on the eyes, okay, we're going to look at them. We're going to open our eyes and we're going to look at the patient, okay? We're going to look at more than what's on this slide. We're going to inspect the eyes. We're going to look at their scalp line as a starting point and determine whether the eyes are in normal position. They should be about a third of the way down the face. One eye's width apart from each other, and then assess the eyelids and the corneas, the conjunctiva, sclera, irises, and pupils. So the eyelids are going to cover the top quarter of the iris, so the eyes look alike. For we're going to look here for redness, edema, inflammation, or lesions. We're going to look at the corneas. We're going to look. They should be clear without lesions, and they should appear to be convex. When we're examining these, we can do it by shining a pin light from both sides and then straight ahead. We can test the sensitivity by lightly touching the cornea with a wisp of cotton, like a little cotton ball. The irises should appear flat. Should be the same size and color. Okay, when we are, and that's where we're going to test the position and alignment, or look at the position alignment of the eyeball in the socket. They're going to be symmetrical, like I said, aligned, without any protruding or sinking. When we're looking at the bulbar, conjunctiva, and the sclera, the conjunctiva should be clear and shiny. Note if there is any redness or exudate. Sclera should be white or buff. And when we're inspecting this, we're going to have them look up, the patient look up and gently pull on the lower eyelid down. And then have the patient look down and lift the upper lid to examine, continue examining the conjunctiva. Okay? And then we're going to check the pupillary reaction to light. And when we're assessing this, we're going to come in from the side. We're going to use a pen light. Okay, we're going to darken the room a little. And then we're going to begin coming in from the side. When you are checking the pupillary reaction to light, the appropriate response is constriction. And what should happen is you shine the light in the right eye, and it's going to constrict. But the left eye should constrict at the same time. Okay? Accommodation. That's going to be, with this, we're going to hold our pen about 12 inches from their client's face, and then have them focus on the pen and tell them to follow the pen. And then we're going to move it closer. The normal response is going to be constriction of the pupils and then convergence of the eyes. So you see convergence here in the picture. Okay, when we are looking at the ears, this is the anatomy of the ears that we're looking at here. Okay, we've got the external ear. We're primarily going to be looking at the external ear. We're going to see the flexible. It's going to be flexible. It's going to be mainly elastic cartilage. It contains an ear flap. okay, which is going to be the auricle or the pinna, okay. Um, it's going to be, um, we will have uh, the auditory canal, and that's the part that's going to get the sound and then transmit it to the middle ear, okay. We'll have the lobule, like I said here. Okay. Then I don't have a picture of the internal ear, but we will be assessing that as well. We will be, or the middle ear will be assessing. The tympanic membrane sits there. It's going to separate the external and middle ear. The center, or the umbo, is attached to the tip of the long process of the malleus. The eustachian tube connects the middle ear with the nasopharynx, equalizing pressure on either side of the tympanic membrane. Okay, when we are going to perform an ear exam, we're going to use an otoscope. Okay, we are going to position the client to where we'll be able to see. You don't want somebody standing. You want them to be a little bit lower than you. Maybe you may even bend down to them. You want them to sit, would be preferable with their back straight and their head kind of tilted a little bit away from you. And then we're going to, with an adult, we're going to straighten the ear canal by grasping the auricle and pulling it up and back. Always remember, adults, we're going to, with eardrops or with anything, especially when we're doing an otoscope exam, you're going to pull an adult up and back. With a child, you're going to pull it down and back. So be down and back for a child. You will pull that and think a child falls down and back, okay? Okay, positioning the scope, we're going to hold the otoscope between your thumb and fingers. Now, everybody's going to hold it a little differently. I hold mine upside down because I can get a better view that way. Okay, you don't want to injure your patient, so you have to be careful with this. You're going to hold it firmly, and then you're going to have one hand against the patient's head so we can keep from hitting the canal with the speculum. We're going to insert the speculum a third of its length gently down, forward into the ear canal. We don't want to touch either side of the ear. Once we're in there, we're going to start looking, and once the otoscope's positioned properly, you'll see the tympanic membrane and the bony structures. The tympanic membrane should be a pearl gray color. It'll be glistening and transparent. We're going to inspect it for bulging, retraction, bleeding, or lesions. Major thing we're going to inspect is the light reflex. In the right ear is going to be between 4 and 6 o'clock. In the left ear should be between 6 and 8 o'clock. Okay? The right ear, 4 and 6. So this is something you will show us in your focused assessments. So please remember that the light reflex in the right ear should be between 4 and 6. And this is something that you should get with your partner in lab and look at and get comfortable with, because you will never be comfortable looking in ears until you're there. Okay? I kind of think about it like this, right? The right time to leave work is between 4 and 6, right? Nobody wants to stay late. So the right time to leave is between 4 and 6. But the incorrect time, it wouldn't, so that would be right. That's kind of a silly way to remember it. The malleus will appear as dense white streak at around 12 o'clock. And then the umbo is the inferior portion of the malleus. With elderly people, the tympanic membrane may be a little cloudy. Okay. This is a video we're going to look in the inner, or the middle ear with. Maybe. Okay, I just think that's a neat video that really shows us what it looks like inside of the ear, because it's kind of difficult for us to to figure out what we're seeing and what's normal and what's abnormal, because some of the pictures in the book just aren't really the best, and YouTube is a fabulous reference for us to use. You can find all kinds of videos. Physicians use it all the time now. You can watch surgeries. You can do all kinds of stuff. Okay, some other abnormalities that we may see. One is going to be conjunctivitis. You're going to see this a lot. And this is characterized by hyperemia of the conjunctiva, with redness in the eye periphery. Sometimes we call it pink eye. It usually begins in one eye and can spread to the other by contamination. They're going to experience mild discomfort rather than severe pain. Vision isn't affected except for some blurring, causing watering, things like that. And I know it says that it is mildly discomforting. It is mildly discomforting, but it is something that you want gone immediately. It is awful. You have to be really careful with your patients when you see them like this. You need to instruct them. Women need to change their eye makeup. Don't use good eye makeup. I actually ended up with conjunctivitis in this past December, and I knew what it was immediately. I knew exactly what it was, and I was trying to treat it on my own, see if I could if it was allergies, things like that. And I really couldn't do anything about it. And I had just gotten a new eye makeup, a new eyeshadow, as an early Christmas present. And it broke my heart, but I wasn't about to open it because I did not want to use anything that I had that would contaminate it. You get all new eye makeup, things like that. Okay, and then so conjunctivitis, and it needs to be treated. You can get drops, things like that. It will contaminate others. You'll infect the whole family, friends, all kinds of people. Okay. The next picture is of periorbital edema, swelling around the eyes. If you have seasonal allergies, you've seen this. Sometimes people get this bad just with seasonal changes. Okay, it may not be quite as bad as this picture, but that's what that picture is periorbital edema, and you can get it from allergies, local inflammation, maybe retaining fluid or crying too much. I'm one of the people that if I cry, you'll know an hour later because I still look like I've been crying. I'm envious of those who can cry without you being able to tell. Okay. And the other picture I have up is actually of a perforation. Okay. It's a hole in the tympanic membrane caused by chronic negative middle ear pressure, inflammation, or trauma. Okay. Okay, the Weber and the Rhine test are going to be used. They are going to assess the ears. Okay, they're going to assess for the conduction. Okay, the Rhine test is going to compare air conduction versus bone conduction. So what you'll do with this is you'll hold the tuning fork, which is the weird looking thing in the picture they're holding up to the patient. Okay, you're going to hold it by the little stem. That's what you'll hold it. If you touch the top forks on it, then you are going to impede the vibration. So you need to touch the stem and hit it against the palm of your hand. You do not need to hit it against the table. Okay, I cannot stand the sound of that hitting the table. It is perfectly accurate if you hit it against the palm of your hand. So you're going to strike it against your hand. Then you're going to place the vibrating fork over the patient's mastoid process. We're going to ask them to tell us when they no longer hear the tone. And then you're going to note this in seconds. You're going to move the still vibrating tuning fork to the ear's opening without touching the ear. And then ask the patient to tell you when the tone stops. Then you're going to note this in seconds as well. Okay? With the Weber test, this is you use the tuning fork, strike it the same way, and you're going to evaluate bone conduction. So you're going to put the tuning fork, strike it against your hand, and place the vibrating fork on the patient's forehead, at the midline, or on top of his head. And then the normal results for this are going to be the patient hears the tone equally well in both ears. Okay? If they have a conductive hearing loss, they're going to hear the tone only in the impaired ear. Okay? If they, with the rind, I don't think I got this far. With the rind, normal is going to be air conduction is twice as long as bone conduction. Okay, so that's why we need to list in seconds. Okay, but air conduction is going to be greater than bone conduction, is what we need to remember from this. And this will complete the podcast on eyes, ears, nose, throat, skin, hair, and nails. There will be another one for this afterwards, posted on Blackboard. Please review this. And this does not replace reading the book. You have to also read all the assigned reading.